Good morning, everyone. Thank you very much for joining us for the COVID-19 briefing for CCOs and insurers. My name is Maria Vargas. I'll be facilitating the presentation. And with us, we also have from the Oregon Health Authority, Patrick Allen, Dave Baden, Dana Horganani, Dean Sidelinger, and from the Department of Consumer and Business Services, Tricia Goldsmith and Tasha Sizemore. So it's my pleasure to introduce Patrick Allen.
This is Pat Allen, Director of the Oregon Health Authority. Thanks for joining us. We're going to go through a variety of information to try to update you on current status and then answer questions. This whole situation, it's hard to believe we haven't quite been at this a week yet, and it's very fluid and very fast moving. That means there are questions that you may have today that we can't answer that we'll need to do some work and get back to you on. It also means there are questions that we can answer and we'll answer them, and the answers will change. Circumstances have been highly variable. If we can go to the next slide, an example of that is testing criteria from CDC, which when they first came out were based on travel. Then they became based on hospitalization, and now they're considerably broader. And we'll talk more about those testing criteria as they evolve. The top line status in Oregon today is we have 2 presumed and 1 confirmed cases of COVID-19 in the state. Quick word about terminology. Presumed is when we have tested an individual at the Oregon State Public Health Lab here in Hillsborough and get a positive test. We report that as a presumed case. We then send the sample to the Centers for Disease Control and Prevention. They rerun the test, and if they find that it's also positive, then it becomes a confirmed case. We don't think this is actually a big distinction. The tests are identical, and we don't have much reason to believe that they would come up with a different result, and they haven't in the first one that they ran. Their guidance to us is at the point that we have a presumed case, treat it as a case. And so that's what we do. We also have a large number of negative tests, and Dr. Sidelinger will go over some of the testing data in a little bit. And so with that, I'm going to go ahead and turn the presentation over to Dr. Dean Sidelinger, our state epidemiologist and state health officer, to talk a little bit more about COVID-19. If we go to the next slide.
Good morning, everybody. Thank you for joining us. As you know, this virus was first identified in December 2019 in China. So really, this novel virus has been with us just for a few months right now. In response to this, we've been working directly with the CDC and our federal partners on getting the best information out to the general public and working with our local and tribal public health partners. Since January 21st, 2020, we've had our incident management team working on this regularly so that as issues arise, we can address them and try to be as nimble as possible. The latest case counts, and as Pat said, these change regularly, is close to 100,000 cases globally, with 162 U.S. cases and those 3 cases that Pat identified here in Oregon. The latest data from the World Health Organization on case fatality rate shows that the actual case fatality rate for those cases we have worldwide is 3.4%. This number is larger than the numbers that have been calculated before. We do anticipate that this is, the number is likely lower, but we are focused right now on testing those who are more seriously ill, not just in the United States, but in other countries. So we anticipate that will go down as we identify more outpatient cases. Could I have the next slide? So this is the current status of persons in Oregon. The lower box includes our persons under monitoring. These are folks without symptoms who have had a potential exposure. The initial group of people under monitoring were returning travelers from China who are identified to us by our federal partners, and the local public health authorities have them under monitoring. Over the last week, as we've identified those 3 cases here in Oregon, these are contacts of those cases who do not have symptoms, who are followed regularly by public health, and if they do identify symptoms, they become a person under investigation. Symptoms of this disease for those contacts are typically a fever and lower respiratory symptoms, a cough or trouble breathing. For those who develop symptoms while they're under monitoring, they're under investigation and a sample is obtained. As you can see, we have 45 folks who were tested who had a potential exposure and symptoms who are negative. We have 13 tests currently pending in the public health lab and those 3 positive cases. We do anticipate that this number of folks who are under investigation and folks being tested will increase as we work to increase testing capacity out in the community. For our persons under monitoring, we have just over 100 people under monitoring as of yesterday, with 238 of them who graduated. So that's the current situation here in Oregon. I'd like to turn to the next slide, and we'll talk a little bit about what we do and do not know about COVID-19. So the COVID-19 symptoms include fever. This doesn't occur in all patients, but it occurs in many of our patients. Cough and lower respiratory symptoms such as shortness of breath occur in the majority of cases. Interestingly enough, rhinorrhea or runny nose occurs in just a small number of people. So someone with just a cold-like symptom may not have, is not as likely to have COVID-19. We do know that most people with COVID-19 appear to have mild disease. That's settling out at about 80% of individuals have mild disease and may never even need to seek care. For the 20%, they have more serious illness, and as we've seen, we have seen fatalities with this disease, and that case fatality rate right now worldwide, based on the confirmed cases, is 3.4%. We anticipate that most people, even those who have COVID-19, have mild disease and don't need to seek care at all. And for others who seek care, our messaging has been to ask them to call ahead so they can notify their provider of the symptoms they're having, and exposure risk within the healthcare setting can be minimized. For those who have urgent medical needs, we urge them, as they would at other times, to call 911. Also a reminder that we are still seeing flu cases in our community, and that is a common cause of people who present with influenza-like illness, and it's not too late to get your flu shot. That's a friendly neighborhood public service announcement from your health officer. The old-fashioned infection control measures that we've been using for centuries work in this case as well. We want to try to keep people from getting sick. We don't have a vaccine yet for this disease and wouldn't anticipate that until likely a year or more. So for folks who are sick, we encourage them to stay home until they recover. We encourage people to cover their coughs or sneezes and wash their hands afterwards, washing hands frequently, and trying to avoid touching your face, your eyes, and nose and mouth are some of the best ways to stay healthy. There's a lot of interest in the survivability of this virus in the environment. We know that we think that it survives for a relatively short period of time, on the order of several hours. Coronaviruses have been known to survive in the environment for 1 hour up to 9 days. We think this one is relatively short-lived. The good news is regular environmental cleaning products will work to get rid of this in the environment. Next slide. For testing, the Oregon Public Health Laboratory has been up and running since Friday, February 28th, so a little under a week with being able to test for COVID-19. Until yesterday, under the emergency use agreement that the Oregon State Public Health Lab had, we were following strictly with the Centers for Disease Control and Prevention guidelines, which were essentially to test contacts of cases, whether from high-risk traveling or identified cases in the United States who had symptoms, or hospitalized patients with serious lower respiratory disease that didn't have another cause. As of yesterday, the criteria were opened up for by the Centers for Disease Control and Prevention for providers to test at their clinical discretion based on community epidemiology. We do have capacity within the Oregon State Public Health Laboratory for testing, but we know that there are many folks who would seek care who are asking for testing who may not clinically require that. So for now, we are rolling out some guidance that is still focusing on hospitalized patients with symptoms of viral pneumonia and negative flu tests as we build up capacity in the state, hopefully from our commercial labs, so that we can meet increasing demand from our healthcare providers for testing and COVID-19 that don't have definitive epidemiologic case links or hospitalization. We do testing daily, 7 days a week, with receiving windows each day to do tests. We are prioritizing those tests with contacts who are current cases, who are at highest risk for developing this disease. We do know that the disease is likely fairly widespread in our community. As Pat said, the positive tests are considered presumptive tests, as this is a new test and the CDC is confirming all of those. That process currently takes several days, but the activity to respond to a positive case happens based on the presumptive positive. I go to the next slide. When we have a presumptive positive case, we work with our local and tribal public health departments departments to identify those who had close contact. Because this is likely spread via droplet, we think that it requires close contact to an individual who's sick. That's typically within 6 feet. And so we work to identify household, workplace, school contacts who may have come into contact with someone while they're ill. There are reports of some spread of this disease before symptoms develop and even following resolution of symptoms. So we think that the vast majority of spread, or the most likely time for someone to spread this disease, is when they have symptoms. As we assess positive case contacts, we do ask them to quarantine at home and remain home for 14 days after their last exposure. And if they develop symptoms, we will continue that investigation and identify their contacts. This investigatory process and the testing criteria are evolving as the situation evolves, and I would anticipate updated guidance coming out over the next few days from Oregon as well as our federal partners as we refine this work and try to provide clear messaging to our healthcare providers. I'm now going to turn over to Dana Harganani for the next portion.
Hi, good morning. Just briefly moving on to the next slide. This slide is intended just to give you a brief overview about current coverage and coding and what we're asking you to consider. Want to be clear that currently OHP, Oregon Health Plan, is going to cover the costs associated with COVID-19, including doctor visits, testing, and hospital care. We're working with our PEB and OF carriers to reduce barriers for access to care and costs for members. And we're asking really all insurers to help support members' access during this time and identify any administrative barriers to that end. You can see here we listed a PDF. We can send out additional links after as well. The CDC is keeping an update on current coding recommendations as it relates to COVID-19 and associated testing and illnesses. The CMS has provided a new HCPCS code specifically for the real-time PCR diagnostic test for this coronavirus. And so again, we can send you links after this webinar, but the CMS and CDC websites will be the best sources of ongoing and updated information regarding coding. Next slide, please. There is a tremendous amount of work going on that Pat and Dean have already related to regarding preparedness happening in our state. OHA and our partners are in close contact with hospitals and providers to the hour every day, evaluating capacity and needs and answering questions and sharing information. We are prepared to meet any medical surges that might occur and actively monitoring for any supply shortages. There's a significant amount of multi-agency coordination happening here in the Portland metro area with tremendous coordinated action among state agencies. In addition, there's been an emergency coordination center stood up in Salem to again support our agency operations. We are ready for what we'll need to address as this moves forward.
Well, I mean, I think it's also possible that the nature of the event could cause various systems to become overwhelmed, whether at the local or at the state level, and we're ready to ask for additional help and resources if that happens. I don't want to sort of make it sound like, you know, come one, come all, whatever happens, we're golden, but we think that we're in good shape as we sit right now.
Yeah, and to that end, this situation is evolving, changing environment, and as Dean alluded to, ongoing change in recommendations day by day that we're keeping up to date on, and you'll be continually hearing from us. At this time, we're recommending, ongoing routine in terms of participation in public events, monitoring school situations, but we know that there could be future disruptions to prepare for as this continues to be a changing environment. Next slide. So in closing, we just briefly want to share again what we're looking for you to do. We hope that you'll proactively continue to share resources coming out from OHA, CDC regarding coverage information with your constituents and members. We hope that you will bring questions and feedback to OHA, any administrative barriers or other barriers that we can help to address, and continually engage with your community partners across the state. We will continue to bring you up-to-date information as well. Next slide. Here we have several sites we just want to keep you aware of. Here listed is our OHA website, which we're updating regularly. You can also sign up for receiving regular updated information. 211 is also activated for public questions. We are translating our materials in multiple languages to ensure access and keeping ours. You can feel free to share social messages and videos that we are keeping up to date as well. And then finally here, again, for ongoing communication for CCOs, we encourage you to use your account representatives and innovator agents to route questions to us. And here have our information for contact and questions related to DCDS.
With that, we'll go ahead and go to some of the questions that you put in. I'm going to moderate the first couple of them. This is Pat Allen, but then I need to step out to have a conversation with the governor's office, and I'll leave Drs. Sidelinger and Harganani to moderate the rest of the questions. First question is, will OHA reduce the administrative reporting deliverables if the system is stretched? The answer is yes. We're willing to consider doing that depending on what circumstances are. What we expect ranges from, not a lot of impacts to significant, potentially a significant impact, and our consideration of reporting will kind of be scaled to that. Right now, this looks like it could be something like a very bad flu year, and we've had very bad flu years before, and we'll have very bad flu years again, and that wouldn't be the kind of thing that we would think requires a response to suspend elements of the contracts. But we'll take that as it goes. Second question is, what role does OHA envision for CCOs for providing support to local clinics? What support can CCOs expect from OHA? I'll take a first crack at that, but then turn it over to Dr. Sidelinger. For local clinics, one of the best things that you could do to help us out, to the extent you can, is try to consolidate questions that they have rather than have them pinging us one by one. We have made arrangements to significantly expand our capacity for answering those questions, but anything you can do to find out the things that are on their mind and consolidate those answers and be a conduit for that information would be super helpful in that circumstance. Dr. Sidelinger, anything you want to add to that?
I think that's the main thing, and we're committed to add guidance updates, to pushing that out in multiple avenues so that everyone has the latest guidance, everything from infection control to testing and other things. And frequently asked questions, both for healthcare providers and their patients, are posted on our website. So going there first and looking to get the answers there before calling the questions would be a great help.
In terms of support from OHA, this is a full-blown incident management circumstance, and so if you have needs, let us know what those needs are. We're able to put them in the queue with whatever else is going on and prioritize them, and through that incident management process, be able to respond to what your needs are. And so they basically just need to be gotten to us, and we can figure out how to deal with them. Third question, and then I'm going to turn it over for moderating to moderating to Dr. Sidelinger. Do we have any guidance on the cost of the test? Do we have an established fee schedule?
Sorry, on that one specifically. So for the current test that's being done at the Oregon State Public Health Laboratory, there's no cost for the test. As for other parts, the visit and collection of the sample, there should be no copay or cost to the patients, as this is covered under kind of an emergency conditions here in Oregon. So there should be no cost to the patients for that additional piece of the testing, but there currently is no cost for the test at Oregon State Public Health Lab. When the commercial labs come on board, they will have a fee schedule that we don't know what that is yet, but we anticipate that would be covered as well.
Thanks, Dr. Sidelinger. This is Dave Baden, CFO. I'll try to pull up some questions that we got from CCO and Insurers ahead and ask the group, and we'll take it from there. And please, if you do have additional questions, we're moderating the webinar question box, and we'll pull some from there. One, I think this has come up frequently around stigma. How do CCOs reduce anxiety, fear, and messaging to patients? What are best practices around that?
So viruses don't discriminate. So we know that anybody who potentially comes in contact with this virus could get it. It's not a specific racial or ethnic group. Initially, we did see cases only associated with travel, but now we know that there are some cases in our community and some potential exposures in our community. So we encourage kind of getting that word out that that there aren't particular groups who are at risk, and that at that same time, everyone should take steps to help protect themselves. So basic hand washing, covering coughs and sneezes, and staying home when you're sick And that's the way you can protect yourself, your family, and the broader community, no matter who you are.
Next sort of set of questions, there were if this goes down the road and there's recommendations for closures or CCO offices or insurers offices that are closed, questions around business recovery plans and having to file paper-based grievances or other notifications. You know, obviously, if we get to that point between us, and I'm sure DCBS would say the same thing, we is clearly will adjust whether it's contract deliverables, other things that we would expect at that point. And if we get to where the situation warrants more, that will clearly communicate more around how we would potentially adjust.
I would say from a preparedness perspective, it's a good time, as we have here at the state, to look at your continuity of operations plan to see what you would do if you have significant numbers of employees who are out sick or other things that may affect your daily business, or if we get to the point where we're recommending that people try to separate, which we're not now, who can telework, which functions can be done remotely, and think about looking at those plans and how they might roll out now, so that if called upon to do it, it's fresher in people's minds and there's been some sort of practice or rehearsal.
Lots of questions, both in the public, and I'm sure from many of you, about larger public gatherings, meetings, etc. So a couple of specific things, and then I'll turn it over for others. So, for example, we got questions about, there was a CCO 2.0 conference that we are postponing, not because of COVID-19 and large public meetings, but more because of the resources that the agency is having to dedicate toward responding publicly to COVID-19, that we just couldn't support that conference from just a workload and workforce perspective. But just generally, Dr. Marganani or Dr. Sidelinger, any sort of guidance about meetings at this point or large public gatherings?
I think at this point, there's no specific recommendations about canceling gatherings. I think if we see changes in the spread in the community, more serious illnesses, that may have to change. As Dave said, right now, our OHA staff is working very hard to respond to this. So some additional things are canceled. You may be pulled in multiple directions on top of your usual business because of that. And so it would be understandable if you have particular staff who's impacted by responding to this, that you may postpone or do things a little differently. Remote meetings typically work fairly well, though, as sometimes we have technology issues. It's a good time to practice some of that. But right now, we are trying to work forward that we're not canceling events because of this infection.
A question came in around emergency funds and sort of funding flowing into Oregon and how that will be made available to providers, hospitals, and responders. So there's obviously a lot of national press and news about Congress passing an over $8 billion supplemental bill to support the nation's response to COVID-19. Obviously, that just passed. So we're how much and how all of that will flow to Oregon is still a little bit up in the air. As we get more information and about how potentially money would flow to OHA, to other agencies, we'll communicate more once we have more information about funding would flow. On sort of the lower level, if there are immediate needs around personal protective equipment, I don't know, Dean, if you want to talk through sort of what would need to happen with those type of requests.
So we know that, personal protective equipment has been kind of in short supply even prior to this, particularly with N95 masks. So we ask that we're following kind of our routine processes, that healthcare systems, healthcare organizations are using their usual process for supply replenishment. If those supplies are not available through that, we have our preparedness program that does have some cash here in Oregon. That's cash, C-A-C-H-E, not money lying around. And so those requests would come in through our local public health partners, are examined and then followed up so we can get those supplies out. We have been able to meet those supplies as they come in and are reviewing each of those as they do come in. We know that our federal partners have worked to try and increase the supply of N95 masks and other personal protective equipment, so we hope that will help alleviate some of the current shortages we're seeing. We are also cognizant of supply chain issues from China, as they're still hard hit by this, and not just our PPE, but many of our other supplies in the healthcare system come from China, with a special reliance on some of our drug classes, antibiotics, birth control pills, and cardiac medicines that come from China. As of now, we haven't identified any specific shortages in those areas, but we continue to monitor.
A couple questions came in around telemedicine, and I think we brought that up a little bit earlier about that as this goes forward, potentially a better time to utilize telemedicine, but just concerns about how patients would have access, the technology on their end, concerns whether on the CCO or the insurer side, provider side, about how best to use. Obviously, there could be billing questions that would come along the way. I don't know, Dr. Harganani or Dr. Sidelinger want to talk about sort of telemedicine thoughts.
Sure. This is Dina Harganani. I can start. First, I just agree. I think just generally from a public health approach, we want to make sure that not everybody is flocking to the clinics or emergency room. So encouraging folks to stay home if they would normally be seeking care, self-care and monitoring at home. We do agree that the opportunity for nurse triage, telemedicine opportunities as well, are clearly something worthwhile to make sure you know what your current coverage is to augment access to those opportunities. We do understand that there could be some limitations with regards to coverage and technical supports for this. We currently at OHA are pulling together teams across our agency to both assess our policies and ways that we could limit any barriers. If you are identifying administrative barriers from your end that you think we can help with, please go ahead and reach out to us. Beyond telemedicine, we're also just thinking broadly, how can we ensure ongoing access to needed care for individuals? Things like pharmacy prescriptions, durable medical equipment. So we ask you, just like we are doing, to take a broad look at where our policies and access issues might be to think about how we can be creative to support our members at this time.
Great, thanks. So we've been hogging the phone a little bit on the Portland side. Just wonder on the DCBS side, Tricia or Tasha, if you have any things that you would like to add from the DCBS perspective?
Yeah, this is Tasha Sizemore, and I'm the Life and Health Program Manager over at DCBS. And I think that when it comes to telemedicine, many of our insurers do have telemedical resources set up. So that should alleviate some of those concerns. Under Oregon law, there is a requirement for insurers to cover telemedicine. So, reaching out to providers in network and finding out what kind of barriers they're experiencing and relaying that information onto the division and letting us help sort out those barriers would be very, very helpful. Especially in rural areas where internet isn't quite as fast. If you are hearing reports in those areas, please let us know as soon as possible. Tricia, is there anything from a consumer perspective?
From a consumer perspective, they can give a call directly to us. We also have an email inbox that they can ask questions. In addition, if they are not wanting to file a complaint, but actually just trying to seek answers to some questions. So we have advocates available to take those calls and to respond to any email questions they have coming in.
Great, thanks. So I think looking sort of at the questions that we got ahead of time and the questions that we've received on the webinar, I think we probably covered most of the main areas that we got questions ahead of time, and sort of the questions that came up in the webinar. There are a couple more specific questions that have come up in the webinar that I think would be good to follow up on some specific coding and some other things that I think we just want to make sure that we're giving the right answers. So we need to do a little bit of research on those. About posting the slides. Yes, we'll work on posting or sending out the slides to the group.
Yeah, on this slide, though, just remember that the numbers that we're listing there are going to update daily. So just make sure that you keep apprised of the information available on the website for that up-to-date information.
All right. Okay. With that, I very much appreciate everyone's time, and everybody please practice good public health prevention and wash your hands, and everybody have a healthy and safe stay. Thanks.